Hello, and thank you for this great opportunity to speak to your group. And I'd like to recognize my fellows who contributed to this talk. It's going to be about the expanded indications for reverse prosthesis, but also our experience here at Johns Hopkins with reverse total shoulder arthroplasty. These are my disclosures. I am a consultant for Stryker Corporation, but I really don't have any of their implants in this talk. The goals are to understand the wider group of indications for reverse total shoulder arthroplasty and also my experience and philosophy of use for reverse total shoulder arthroplasty. It was designed primarily for cuff tear arthropathy. This is a fairly classic acetabulization of the shoulder joint due to a torn rotator cuff with superior subluxation, pain and loss of function, as you see in this individual with superior subluxation. It was first approved in the United States in 2004, but it was approved for only cuff tear arthropathy. First, the systems available in the United States were by DePuy and Tournier, and now there are, of course, about 25 or more systems available in the market. So the market has significantly increased in the recent past. The earliest literature was by Dr. Walsh. It was a multi-center study, and these were sort of the initial results that were quite excellent. They did have some failures at the first year mark with infection dislocation as the primary causes, but they had concerns that after 8 years, patients complained of pain and weakness. So they did caution about the long-term results and initially said that this operation shouldn't be done on patients under the age of 70 years of age. That, however, has changed quite a bit. Reverse shoulder arthroplasty is now the most common arthroplasty inserted over total shoulder arthroplasty, not only in many programs, but in many countries. The indications have expanded for conditions that in the past we had no previous good solution, and this includes not only patients with rotator cuff tears, but with bone loss and many other conditions. So this is our experience at Hopkins. These are our anatomic arthroplasties that were performed since I started around 1995. And you can see that they slowly tailed off around 2017. This is the experience going up through 2017, and you can see that the majority of the prostheses are almost now reverse arthroplasty. So the best indication for reverse arthroplasty is pain. This is a pain-relieving operation. We tell people that the goal is to regain the motion as much as possible, but we consider a good result the ability to reach the top of your head without pain and improvement in your ADLs. There are some precautions, however. You want to avoid young patients who sometimes do things like this where they have accidents and fracture their shoulder. You don't want a non-compliant patient, patients who fall frequently or have seizures, and also avid sports participants who tend to fall and break their arm or their prosthesis around the arm. Here's a good example of a cuff tear arthropathy. I showed this earlier. This gentleman has very poor range of motion. You can see that he's had a previous operation there. This is him post-operatively, very happy, has no pain. This prosthesis was an early DJO prosthesis that's cemented. Don't any longer cement stems, but they do quite well without cement. You can use it for people who have rotator cuff arthropathy after failed rotator cuff surgery. This woman went on to have a pretty good result. Unfortunately, she has a little bit of pain because she fell prior to this video, but she is actually quite happy. Osteoarthritis with rotator cuff tears. This patient has severe osteoarthritis, but she has a small rotator cuff tear. Rather than fix it, we went ahead and did a reverse total shoulder arthroplasty. I should add that she's our oldest patient to date. She's 95 years of age. This is her result. Not too shabby. I take that any day. The other indication is osteoarthritis with glenoid bone loss. This is a large group now. This gentleman has a very thin rotator cuff, but it's not torn. But he does have significant glenoid bone loss and medialization and posterior wear. Here he is with his prosthesis. and some of these patients are the happiest. In our experience with glenoid bone loss, we reported 2-year follow-up on 42 patients with a variety of different glenoids. When you reclassify these, most are B3 type glenoids with only one type C. So the classifications changed a little bit, but we did just recently report this month, in fact, in JBJS, our 5-year results on this cohort of patients. We had scapular models made using CT scan on all the patients, so we had a good idea of what their glenoid really looked like. We did eccentric reaming only. I was initially very worried about medialization with reaming them flat, but we now use modeling to know exactly how much bone we have to take off to make it flat. With a minimum of 5-year follow-up, we had 2 base plate failures, which is around 5%. One was a type A2 glenoid and one was a type C glenoid. About 19% had notching, not only at 2-year but at 5-year follow-up. And at both time frames, all patients in both groups were happy with their result. One way, though, that we should think about this study is that we used only one device, which was a screw-in type base plate with central fixation. Did have peripheral fixed screws or locking screws. The amount of bone was defined by coverage on the base plate, which we set at around 80%. So we don't have great significant bone loss in these patients, but I'll show you our solution for that later. You can also use this for immunologic arthritis now. This is a patient with severe rheumatoid arthritis. This is her result. She's very happy. She has great range of motion and no pain. You can also use it for patients who have a failed hemiarthroplasty. This gentleman had so much pain he wouldn't even lift his arm. You can see that he has eccentric wear superiorly and central wear medially. Here he is with the result. This is what you want. You want a happy patient and who has good motion and good function. This is a gentleman who had about 7 previous operations. He too had a failed total shoulder arthroplasty, which had been removed in terms of the glenoid component, but he also had brachial plexus explorations. He had very little motor function, and we did a reverse on him, and here's his motion. He's a retired plastic surgeon, by the way, and you can see all the debris from previous operations, but he's done extremely well. They're also very good for acute proximal humerus fractures. These are oftentimes 4 parts, but sometimes the head is split and there's just more parts than you can count. This is a woman who had a proximal humerus fractures. She doesn't have great range of motion, but she is very happy because she has no pain with motion, which is probably the major advantage of a reverse over hemiarthroplasty or internal fixation. This woman had a malunited proximal humerus fracture. She was handicapped, however, by having poor external rotation. I don't really use latissimus dorsi transfers because I think the results are somewhat unpredictable. Other authors and surgeons have better results, I think, but as a result, with her surgery, she was pain-free, but she did have still some limited range of motion. We've had several patients who have fixed dislocations, usually anterior. They get significant anterior glenoid bone loss. This is a gentleman who's in his early 30s who had a glenoid fracture that had malunited, and basically this was the only solution, and he's had fantastic motion even at 5 years follow-up. You can use it for all sorts of dysplasias. Here at Hopkins we have a large genetics group, so we see all sorts of different abnormalities. This is a woman with a kind of dysplasia. These are her results after surgery. She actually is pain-free, believe it or not, but her motion was not significantly improved. So there are limits to what this operation will do for her. There are also lots of reports about using it for tumors. Our oncologists use it as well. And I've been involved in a couple of their cases, but by and large, they're fairly self-sufficient. The youngest patient in our series is this gentleman who's in his early 20s. He had multiple operations for recurrent posterior dislocations from seizures. This is his result. He's got great range of motion. We do have 8-year follow-up on this gentleman. He's had no problems thus far. So why not use this all the time? The complication rates can be as high as 70%, but that's usually in the early studies. Longest term follow-up shows survival around 90%. Could it be the next metal on metal hip and a disaster? We really don't know. There are some bad results like this. Most common complication is notching. It's worse with or associated with poor results. Again, we don't know if this is a time bomb going to go off sometime in the future. Latest thing though is custom glenoid components. We use it for patients with very severe glenoid bone loss. They usually have too much bone loss even for effective bone grafting. And I'm not a very fond of bone grafting around the glenoid anyway. Basically what we do is get a CT scan and we trial it to see if we can get a good fit. And then we create a trial. We then make the reel. And this whole process takes about 2 to 3 months. Implantation can be somewhat tricky, but the long-term results have been pretty good so far, but they're not extensive. One problem with this is that the implants are fairly expensive. So in conclusion, there have been expanding indications for the use of reverse total shoulder arthroplasty. Long-term results have been promising. I personally think that for a majority of cases, you can use eccentric reaming. For those who have significant bone loss, then I favor a custom implant right now. The future is yet to be known in terms of how they do, but I think this is a good algorithm and what we use in our practice. Thank you very much, and look forward to any questions.